views, information, or opinions expressed during AAOA broadcast series are solely those of the individuals involved and do not necessarily represent those of the American Academy of Otolaryngic Allergy, its employees, or members. The AAOA is not responsible and does not verify for accuracy any of the information contained in and assumes no liability for any activities in connection with these broadcasts. The primary purpose of this broadcast series is to educate and inform and does not constitute medical or other professional advice or services. Advertising which is incorporated into, placed in associate with, or targeted toward the content of this product without express approval and acknowledgement of the AAOA is forbidden. These broadcasts are available for private, non-commercial use only and may not be edited or modified from their original form or reproduced for distribution.
Good evening. My name is Doug Dawson. I'm an ENT and allergy person from Southeast Iowa. And tonight we're going to talk about allergy reboot in the COVID era. And I want everybody to go around and introduce themselves and talk about conflicts of interest. I don't really have any. I'm an employed physician in a large multi-specialty group, Unity Point Clinics. We're in 3 states, Iowa, Illinois, and Wisconsin. So I work for them and I hold various positions with them, but otherwise no conflicts of interest.
Thank you for this opportunity. I'm a private practice otolaryngologist, practicing largely general otolaryngology, rhinology, and allergy. We're a 10-physician group with 8 PAs. I'm practicing in upstate New York, and allergy is a very significant part of our practice. My conflicts are I am a consultant for Stryker, am involved in clinical trials for Latera and Clarifex, and am a minority investor in IoTech International.
Okay, Mike?
Hi, thanks, Doug. Appreciate the invitation to be here. I'm Michael Platt. I'm a rhinologist at Boston Medical Center, which is an academic university setting, and I practice rhinology and allergy. My conflict of interest is that I'm a consultant for GI Reviewers, which is a company that reviews research studies on polyp biologics.
Dr. Laury.
Hi, I'm Adrienne Laury. I am a private practice otolaryngologist in the Seattle area, and I have no conflicts of interest to disclose.
Okay, Dr. Crosby.
Hi, thanks for having me tonight. So I practice at Southern Illinois University, which is an academic institution in Springfield, Illinois. I'm a rhinologist and run our allergy program, and I'm also the residency program director there. I have no conflicts of interest.
All right. Dr. Sassler.
Hi, Doug, and everyone else. Thanks for including me in the group tonight. I'll do my best to contribute. I am I guess a veteran otolaryngologist. I've been doing allergy within my practice for 30 plus years. Have time in the military, time in rural private practice, and for about 9 years now have been full-time faculty at University of Cincinnati, where I'm a generalist and I run the allergy program and do a lot of rhinology as well.
All right, thank you. Dr. Connolly.
Yes, so Jim Connolly. I am in private practice in sleep medicine, allergy, as well as general ENT in the greater New Orleans area, and I have no conflicts of interest.
All right, so as we can see, we all come from across the country and probably have a pretty disparate experience with the pandemic. So what I think we should do now is kind of briefly go around and talk about that. How has this virus impacted your practice? Did you have to shut down, furlough staff, etc.? Let's give a couple minutes, everybody, on that. And whoever wants to start, we'll just kind of go through things.
Okay, so I'm in upstate New York, not quite as ravaged as downstate, Manhattan and the boroughs and so on, but in late March, the 3rd week in March, we went from a busy in-person practice literally to only emergency in-person visits, closing the practice, including the allergy side of the practice, and transitioned literally overnight to telemedicine and have remained in that posture up until this past Monday, when we reopened the allergy practice, knowing that the volume of allergy would be very high and allowing that to settle out before reopening on a limited basis the clinical part of the practice and all the other ancillaries this Monday coming. And as I'm sure we all know, allergy patients are very committed to their allergy shots. And on the first day, we had an overwhelming return of patients to the office, and we can talk about that and managing those kinds of aspects a little later on.
I can talk a little since, so in Seattle, we've been shut down for probably the longest since we were the initial people to raise the red flag. We shut down the first week of March, so almost 2 months now, and went to a lot of similarly telemedicine and really only seeing urgent and patients in the clinic. We actually did transition some of our shot patients to SLIT during this time, interestingly enough, and did their first initial SLIT over telemedicine with them. They sat with our nurse and they administered their SLIT, and she watched them and trained them in the meantime how to use an EpiPen just like she would normally in the clinic. And we took that opportunity to transition some of our patients at that time. So it was an interesting change of pace for some people, but it's kind of welcome from some people.
So that's a really interesting topic, and I think let's put that on the parking lot for just a second and kind of finish going around. But I think that's something this thing has possibly brought out. I think we should come back to that conversion skit to SLIT.
So I'll speak to the Eastern Midwest, the Cincinnati, greater Cincinnati area. We're a border between Kentucky and Ohio. We've had two governors that have been very proactive, and social distancing and things getting shut down started about 6 weeks ago. So we are blessed with a blunted curve, which is great. A lot of the contingencies that were planned where physicians and other providers would have been taken out of our practice to be utilized elsewhere in the medical center, that has not come to fruition. Nevertheless, we too transitioned to telemedicine virtually overnight, and have learned a lot about that, and they're using that a lot. Our allergy practice went on even through the slowdown in various ways. We can talk later about how that was individualized to the patients depending on the situation. We have a pretty busy allergy practice of about 700 active patients. So there was a variety of solutions that were utilized. We do use both SLIT and SKIT in our practice as well.
Dr. Crosby.
Sure. So I think pretty similar to what others are saying. We stopped seeing patients on kind of a more normal or regular basis on March 16th. So it's been about a month and a half now, and we really were only seeing urgent or emergent things in the office. We very quickly transitioned to telemedicine and have been seeing most patients in that fashion who are appropriate for telemedicine. Our allergy practice did completely shut down and will remain shut down probably for another month or so. And so I think that I can kind of speak from the aspect of really kind of having to shut things down. And, you know, I think here in Springfield, Illinois, we haven't seen a significant number of cases relative to some other places. However, right now we're starting to see our own little mini surge. I think being a more rural area, we're going to see a little bit of a later peak than some of the major cities.
Right. Dr. Connolly, New Orleans.
So I would say it's pretty similar to everybody else's experience. About 6 weeks ago, we had to shut down and convert over to telemedicine very quickly, as being one of the hot spots. For us, our practice, we were blessed that we have an ambulatory surgery center and a spa that's connected to our building that obviously had to be shut down at that time. So it allowed us to quickly be able to transition into a shot therapy at the curbside through a drive-through, and we had extensive parking for those other components that were shut down that we could use. That has turned out to be very, very helpful. We did have to shut down for a week or two, setting that up, but the patients have been very, very happy. It's been, I a nightmare with the pollen counts where we are and the amount of people that were having problems. And of course, everybody was wondering if they have coronavirus because some of the symptoms are exactly the same. And so we've had a lot of positive feedback for that. One of the things that we're most concerned with in our practice is, are these patients all going to expect this type of service forever? We did try to convert people over to SLIT, as Adrienne had mentioned. Our issue with that is we also have a lot of patients that have lost their jobs. And so the ancillary income for that may be really the rate limiting factor that we see in our patient population, but it's a great option.
Mike, how about Boston?
We've been completely shut down, actually. All elective care stopped at our medical center in our department. So it wasn't essentially my choice. The department shut down. And so I haven't done any testing or given any injections since about mid-March. And that continues through now. And I can see emergencies, I see telehealth, but my immunotherapy practice is on hold.
Okay, so here in Iowa, it's similar Midwest story. We had an impact on the 16th of March as well. We took 2 weeks and shut things down for immunotherapy, then started right back up with social distancing and putting a shop patient in the room, since we had really nothing going on except for emergencies. I saw peritonsillar abscess, stuff like that, not anything else. So sleep medicine, the sleep lab closed, things like that. So what kind of resources have you used? What kind of things are you using? The Quad AI's little practice parameter on how to delay shot therapy. What are you guys thinking about in terms of any adjustments you've had to make with backing down doses, lengthening doses? Basically, the Quad AI said if somebody's on maintenance, you could go out 6 weeks between shots or longer if needed, without doing much in terms of adjustments, and depending on those other modifiers in the environment, not only just their health, but whether they're asthmatic comorbidities, and then what's going on in your community. I think that's something, as we go forward, we're going to talk about, that the community's impact, how it's impacted by the virus is going to really make a huge difference in our practices, whether there's a second wave, et cetera. And we need to be aware of that, almost like we're asking that question of a patient coming in along with the other standard questions we ask. So what's everybody's experience and how they've adjusted their shot therapy or conversion to SLIT? I think this is a really good conversation.
So probably at the end of the first week in March in New York, we already saw patients returning to the office less frequently because of concerns about exposure, social distancing. And so there was a natural turn down before we closed. And I think when patients had difficulty transitioning through the season, when we restarted, they were enormously resilient in terms of coming back. One of the difficulties, like Jim had mentioned, with transitioning to SLIT is that the out-of-pocket was a concern. And I think people are having a lot of economic concerns and not willing to make that another additional fixed out-of-pocket cost. We did continue our SLIT practice. We have about 500 patients on SLIT. They continued unchanged, and we would make vials and mail them instead of coming in, depending on where the patient lives. And then what we did in the slowdown and the ramp up is limit testing and dose escalation to limit the 30-minute wait so that we could limit the amount of exposure and crowding potentially to manage that better. So since we've restarted, you mentioned the Quad AI materials, but the AAOA materials that were released yesterday provide excellent guidance, and the table resuming skip during the COVID-19 pandemic gives an excellent breakdown for dose escalation and maintenance treatment. And as you point out, I think the key is it's on an individualized basis, depends on comorbidities and individual patient, but being able to restart the practice safe distancing and other measures, limit exposure, limit aerosolizing procedures, to safely administer patients and get them back on treatment at a difficult time of year. That's been the challenge, and I think patients have responded well.
Yeah, that's excellent. Yes, we did have the website. If you all haven't had a chance to review this, we call it out to our membership and anyone viewing that resuming SCIT during the COVID pandemic is one of the new topics or one of the new items on the website, with a really excellent, as Gavin said, really excellent table in there of adjusting doses or what to consider going back. And just want to give a shout out to Dr. Platt for his excellent work in terms of carrying the load on this. It was a group project, but really, Mike, thank you. So, yeah, anybody else's comments about that? Go ahead.
I think this is Al Sassler from Cincinnati again. First I do want to thank, I didn't realize it was Mike that spearheaded that piece that came out yesterday. It's a really nice compilation of suggestions and nice pearls on firing back up the shots after a gap. And I think it looks to me like it included a lot of the quad AI materials or suggestions as well. So very helpful, nice and succinct. I think first you have to think about, we all think about safety of the patient, safety of the staff, safety of ourselves. So social distancing, spacing patients out in the office and in the waiting room in particular. If you are having people who have to wait, the sort of nice thing was that most of the patient load kind of had to settle at, had to not be there and was switched to telemedicine. So the waiting rooms weren't very full. So that was helpful for us. We did individualized care. Initially, 6 weeks ago, there really wasn't much guidance. So I must say that I tried to use my best judgment, keeping safety in mind, cutting down load on the healthcare workplace for everybody, patients coming into the spring season, trying to prevent the asthma patients from having exacerbations by maintaining their allergy therapy, et cetera. So we really did individualize it, keeping all of those thoughts in mind, and not trying to overuse PPE either.
Doug, I can comment on the idea of changing from SCIT to SLIT. And so I think that it is a reasonable option to do it, and it's also reasonable not to. In fact, in my practice, I've chosen not to, but my partner, who practices alongside me, is doing that. And I think that whatever you choose to do during this time, we're all getting creative, doing things a little bit differently, trying to find new ways to do it. I think that the main thing is we have to maintain safety and then also consider standards of care. And so how would I change someone, or how would I start SLIT within the usual practice? You need a special consent. We have a special consent that describes the out-of-pocket costs and the off-label use for aqueous SLIT. And then the on-label versions, the tablets, require that you have the first dose in the office. And so you have to have some consideration of where they're going to have their first dose. And then there's the epinephrine auto-injector as well, which isn't just prescribing it, but also the education for how to use that. And so those are all things which I think are the usual practice for providing sublingual immunotherapy. And I think that as long as you account for all those things in some fashion, that you can execute it. I happen to be at a safety net hospital, so it may not be as applicable with the outer costs for those patients, but I think it's a reasonable thing to do. I choose not to, but I think it's reasonable as long as you continue to follow those standard of care guidelines.
So obviously patients that are able to do their transition to SLIT, we ideally normally, of course, have those patients come in and sign their consent in person and do, their first drops in person and get trained by our nurse and how to use their EpiPen. And we kind of went a little rogue and had them sign those things, and fax it back to us. And then we had them do a telehealth with our nurse to learn how to use their EpiPen. They had to show the nurse that they had the EpiPen, so they would, show it to her visually on their telehealth. And then they would do their drops and she would go over all the potential reactions of it. And we felt a little bit safer because we know this person this wasn't our first introduction of an allergen ever to them. They had received SCIT for usually several months beforehand. And most of these patients were already actually on maintenance, and they decided to switch. So we didn't feel quite as risky, but it was definitely, for my allergy nurse who has been doing this 30 years, and she's like, I just feel a little anxious about this, and rightly so. But as everyone keeps on saying, these are unprecedented times, and sometimes you gotta break your normal rules. And I don't think we did it in an unsafe way. I think we did it kind of in the best way that we could, still with kind of maintaining some semblance of our normal rules that we follow with this.
Has anyone started, have they adjusted the dose of anyone on maintenance? Are they continuing shots on folks on the building phase? How are they dealing with their IT? Because really, I've done most of mine that are on maintenance. I've kind of kept at a lower dose with those that I'm not advancing anybody on the build. So
I would say that, so from our standpoint, it's been about overloading the hospital system, right? So we're trying to protect our PPE, and we're trying to protect our hospitals so that if we're putting people at risk, that at least we have those resources there. So at first we did not escalate, but as our hospitals have come to a steady state and declining state of admissions and patients on ventilators, and now we're moving ahead with more surgeries, that we've started to escalate again in those patients that are not at high risk.
We're doing something similar, and our cycle has been about 4 to 5 weeks, so not as much disruption, particularly for patients on maintenance therapy, but dropping back a dose or two, or if they're 3 weeks out and we're starting to escalate, restarting them, just to be able to do that safely and on an individualized basis. And then, you know, the value of a test dose, and that's very helpful too. But apropos some of the earlier comments, this may be an opportunity to lobby for coverage for sublingual immunotherapy, given what's transitioned. And we were actually approached by one of the large local insurers who do not cover it, about why we're not offering it at this time, and a willingness to revisit that. And maybe, you know, looking at home immunotherapy, which is something that would have to be a much larger discussion with the AAOA.
Just to jump onto those comments, the actual cost for SLIT, depending on the insurer, SLIT versus SCIT, some of the copays are actually shocking these days, even just for an allergy injection. And we've worked hard with the university to try to keep the cost of SLIT as low as we could. And we actually have patients in our area who the costs are comparable. So we're able to offer it as a real viable alternative. Although, as was pointed out, if somebody loses their insurance and loses their job, it's a different discussion. I totally agree. It would be a great opportunity to be able to lobby right now. Perhaps the time is right for that. That's encouraging what Dr. Setzen mentions about his area. We do have both in our practice, and we have had a few patients switch to SLIT during this. But mostly we kept people where they were in terms of the type of immunotherapy. In terms of dosing, people that are on maintenance, we're given the opportunity to space it out a bit vis-a-vis the Quad AI recommendations and now the AAOA recommendations. People that we're building, it really would depend on the individual situation, whether they were exposed to known allergens that they were very sensitive to, whether they had asthma that was unstable, as to whether we would continue to build with them. We had some patients who were building that we almost treated them like they were pregnancy patients, where we plateaued them and allowed them to do their shots at home once we trained them properly to do that, and we're comfortable with that. Usually we would like another adult there when that happened. And again, some of this is a little outside of our comfort zone, we would prefer the shots being done in the office, but we had to make some adjustments here very carefully, and also used informed consent appropriate to all of that.
Yeah, so I think, you know, like I said, we have really been, our allergy practice has been shut down. I think as far as some of the states go, Illinois has been pretty aggressive at shelter in place and really only essential medical treatment. And because of kind of the state of our practice, we've had really limited testing and really limited PPE here. So it's been hard to really assess the state of COVID-19 in the Springfield area. And so with that, we've been just very careful. So, you know, I think at this point, like I mentioned earlier, we're thinking of resuming shots probably in early June. At that point, it will be a good 6 weeks from the time that patients had their last injection. Of course, a lot of those patients are going to be in the escalation phase, and I think we'll just need careful attention. And so I think one of the biggest points for me will be to really think about this in an individualized way, and thinking about the patients who are most at risk and spending some time really coming up with a thoughtful plan for those who have had a history of systemic reactions or have more brittle asthma. And so I think just thinking about it in an individualized way is really important. But I am really happy to see the guidelines, because I think that really gives us all a really great starting point to think about and then tailor to our individual patients off of that starting point.
Great, Dana. I appreciate you bringing in an extra consultant for the viewing tonight. So.
Well, I think that there is some difference of opinion in home immunotherapy, and the most current practice parameters published in JACI, as well as the COVID guidelines that the AAAAI just put out, both state that you shouldn't really do home immunotherapy except in very specific rare circumstances. And so I think that a thought has to be given to what are those circumstances. I know we're in different times now, but when you have a practice parameter stating against it, I think you have to be a little bit careful about your liability practicing when you probably will have thousands of practitioners who follow those guidelines and be willing to say that that's not exactly standard of care. So every region's a little bit different, and that's just my personal opinion about those guidelines, that I'm a little more careful about following them just because they are published and accepted guidelines that are out there and haven't restated in the COVID era guidelines as well.
So quick raise of the hands. How many of us allow home therapy or practice with home injections? Anyone? I don't. Yeah. Yeah, so there, well, I think, but that's certainly being discussed. It's certainly a lot of discussion on that, and perhaps a lot of folks following that. I would echo what Mike said, that it's going to be hard unless you, even if you include some of those references in the informed consent, whether you're really informing, you know, the old adage of, I would have never have done that had I known. That's what you're going to hear back.
And that informed consent would likely not hold up in a court of law.
Correct. Correct. So
I want to make one comment regarding that. The recent recommendations are expert opinion, and their recommendations. There are practice parameters as well that Dr. Platt's pointing out. There are also, actually, there's an AAOA sponsored multi-institutional study. It's from the AAOA journal back in 1999, which looked at a bunch of practices and did compare home immunotherapy to office immunotherapy, and looked at rates of generalized reactions, et cetera. And it actually was favorable for home immunotherapy. Understand, I'm not arguing for general use of home immunotherapy, home subcutaneous immunotherapy, but I do think there is some documentation, there is some data to say that it can be done safely in certain situations. And I think there is some literature support for it.
one thing before we leave home immunotherapy, just mention that multiple payers will not cover home injections. So just that as another dissuader, I guess, in my mind. But so we go through this time frame, and we're getting into June, and maybe Mike and Dana are going to restart their immunotherapy. Is there a plan in place or policies in place for the second wave, or having it happen again? Or what have we learned that we're going to apply the next time? Any comments on that? Anyone doing elective surgery? I am allowed to in the middle of May, and that's going to require a COVID test on any patient before they enter the hospital. So
we are starting surgery. We're given the green light from the governor to start again next week. So we have made the decision amongst our group to test everyone before we operate on them. It's being required by all of our hospitals, and we within our ASC have decided to also test everyone preoperatively to provide, well, who knows what it actually provides, right? But to provide some sense of reassurance to us, mostly probably to our nursing staff that's there. It probably provides the most reassurance to them. But it also covers our butts a little, as it will probably for a lot of people. But also because we think as ENTs, we can do the test the best. So I kept been saying this to my partners for a long time. We can test the nasopharynx better than anyone else can. And I think some of these high false negative rates out there for testing is because the tests aren't being done appropriately every time. So we have decided to do it ourselves because we think we can do it the best, and hopefully, I don't know if it's true, but hopefully get a better or a lower false negative rate than what they're producing out there right now in the large community.
Dr. Larry, how young are you testing? What is the requirement for your center?
The youngest there's no requirement for us. For our hospitals, I think they're testing everyone as far as I understand, but for our ASC, we've decided to go down to 10. We're not testing anyone under 10, just, I don't think there's a many magic to that number, but that's kind of what we agreed upon.
Abbott has a point of care test that looks promising, but is not yet commercially available or commercially affordable. And I think, as was alluded to earlier, the reliability of the testing, the false negatives, the timing of testing prior to surgery. For a pediatric patient who needs an escort, do you test the parent or escort as well? I think there are a lot of rate limiting things there. Do you quarantine the patient if they were tested 24 or 48 hours before surgery? So I think that's a little clunky and has yet to be worked out, and likely will come down to regional and institutional recommendations as well.
Yeah, I'd give everybody a heads up to their institution. That's exactly the question that was asked today by our office. We're required to do testing, but they can't tell us exactly how quickly they can turn around those tests, nor should we do something with the patient if it's 48 hours before surgery. Are folks using biologic stills? Have they changed any of their patients that aren't getting home shots on their Dupixent or whatever? Are they still seeing patients for that in the office?
We haven't changed anybody that was already on it, that we're doing Dupixent at home, but we're not starting anybody on that.
Right.
Similarly, and for those patients who had visiting nursing, that continued, or who were on a protocol uninterrupted.
So any comments on the particular second wave that's predicted? What will you do differently? Anyone? Besides not have it.
A lot of things.
What have we learned? Yeah, go ahead, Jim.
I think the most crucial thing for me is that we've been kind of blindly walking through our profession about how many pathogens, and this is just one pathogen. There's a gazillion other ones that we see day in and day out. And although I think all of us felt that we practice very safe medicine, I think we can all be a little bit more honest with ourselves that we could have practiced better. And I think we all will, namely for ourselves and our families, but also for our patients. I think that's the biggest thing that's come out of it for me. But I do think having guidelines and having these discussions prior to the event is so helpful in going through the different decision processes that have to be made, and for our community in general, needing to make that decisions all together, hospital systems, states, local communities, not just your one private little practice in my case. So having everybody already exploring these ideas and knowing what are good, reasonable decisions is going to be helpful. Problem is, the next time it'll be something totally different. So, but for a second wave, I hope it's very similar to the first wave, but just less of a spike.
Is anybody planning, I'll just say that our office is going to do the quote after action kind of summary. When things have settled down, we're going to try and codify what exactly we have learned, what we're going to try and do differently, that PPE store that we really need to keep as a backup, that kind of stuff. Anyone else want to comment on that?
You know, I think depending where one is in the country, for example, in New York, I think it's going to be a continuum. I don't think it's going to disappear and then reemerge, because I think the American psyche is really spooked. It's going to be a very slow ramp up for patients willing to venture out to practices. They certainly are going to be reticent about doing anything in the hospitals. And so I think it's going to be a gradual process, and we'll be in the fall by the time patients have any confidence. And a bad flu season, not COVID-19, will really have, I think, a big impact on psyche and exposure. So how much of this is going to evolve over time, only time will tell. I think what we'll have the benefit of is 2-3 months of additional data and science about, you know, what we really could and should be doing different, and what really is the appropriate PPE, so that, you know, it's more science rather than anecdotal experiences, so that we can base our practice on best data available moving forward.
Right, and I think that's going to be no shortage of really good studies coming on this whole topic. So
there's a lot of silver lining kind of stuff, or I think I see a few. For one thing, telemedicine is a great way to do an allergy follow-up. That's something that I've learned in the last several weeks. I hope that the relaxed rules that suddenly occurred to allow more telemedicine suddenly don't all totally disappear. I hope we can continue to use that. The efficiencies that it can add to a practice look pretty interesting to me. Another thing that's interesting, you know, at this point in my career, I've never ever seen anything generate so much data, so much discussion, so much change so quickly. It's actually quite something to see. Dare I say it's exciting. Now, I haven't gotten it, and nobody in my family's gotten it, so none of my staff have gotten it. So that way I can look at it and say it's exciting. Granted, it's also horrendous. Yeah, we've learned that we need to keep PPE. We've learned about where we can reinfect our patients and ourselves, and I think that's all going to be important going forward too.
Anyone want to make a kind of summary statement of what they really are going to take forward from this? I think some of us have.
You know, I think for me, like I mentioned already, one of the takeaway points for me for considering allergy during this time is kind of just a personalized approach to the patients, and thinking about what their risk factors are and how best to at least try to approach each patient safely. And then the other thing I think that I'm trying to do with all of this is I think for a long time I was thinking to myself, gosh, when is this going to end? And looking for things to go back to normal. And I think the way I'm approaching it now is, I think this is kind of a new normal. And I think that we are going to be in this new normal. I'm not sure things are ever going to go totally back to how they were before. I think we've learned things we didn't know about our specialty before as otolaryngologists. And I think it's kind of opened our eyes. And I think it's just shifting from this idea of going back to what it used to be, but instead thinking about what it is now and how do we most appropriately and safely and effectively deal with this new situation that we've been dealt.
You know, a couple of thoughts come to mind at this time also, you know, with social distancing and much different workflows and throughput in the office. While we've all been able to incorporate telemedicine, by the same token, incorporating as much digital and remote processing as possible, using things like Freesia, Medfusion, you know, forms that can be completed online so that patients can take care ahead of time, consents, histories, insurance verification, and so on. The more that we can do ahead of time, limiting contact and exposure in the office is very helpful, and after the visit as well. What I think is a big issue is all of the PPE requirements, the slower schedules, etc. The cost of providing care now on an individual basis is going significantly higher, and our efficiency is getting significantly lower just because of the reduced volume and social distancing and all the other parameters that are involved. And for me personally, and I'm sure for everybody else, allergy has always been a very special part of the practice because you can offer somebody meaningful care other than surgery or another prescription. And for those listening who do not practice allergy, whether it's subcutaneous immunotherapy or sublingual immunotherapy, this is a great opportunity to really consider that. For one thing, it's excellent patient care, it's very satisfying, and it's also an excellent ancillary service at a time when your practice may be a little under duress. So seriously consider that and look to the resources of the AAOA to do that.
Right, I just would echo that coming soon, a new course online is being prepared. We're going to try and launch as quickly as possible. That's probably 4, maybe 6 weeks or less. But watch your emails and the AAOA website. There's good things happening here, and we'll try and all profit from some of these efforts. And we're going to be doing more of these kind of webcasts or Zoomcasts.
I think my overall take from this is that for me, I'm going to be restarting in the next few weeks. I think safety is the most important thing. And safety is how I'm going to redose, where I'm going to restart patients, how I'm going to back them off, and I have to look at each one individually. And then also probably do a vial test on just about everyone. And so I think that's a really important part of this. And then the other part of safety is the PPE for ourselves and our staff and our families. And I think that we should take that very seriously. And I think that telemedicine, I was a skeptic when it first started. You know, people have been talking about it for years. They said, how can I be an ear, nose, and throat doctor without looking inside the ears, the nose, and the throat? And even some new patients, it's amazing how much the history gives us and how much we're able to treat. And so I don't think that that's going to go away. I think that's going to be a major long-term benefit from all of this that happened. And the thing that I'm most looking forward to is, you know, how are we going to get back to scoping people in the office and doing surgery safely, and what are the protocols and the PPE? And that I really don't know when it's going to happen and what it's going to look like.
Yeah, and just to Gavin's point earlier, I turned back on and now seeing it didn't take me but 2 days to get near pre-COVID volumes back. So, but we have not, our county has not been hit, I believe, like yours. So people are not fearing coming to the doctor. A lot of things are changing. A lot of things are coming, and I think we can all take some lessons learned from this. And as a sleep doc, I can just say CPAPs are going to be changed forever by telemedicine. I just kind of feel that.
Doug, just one comment off of your CPAP comment. You know, where PPE is very scarce and availability of N95 and other masks and so on, we started using one of the CPAP mask sanitization devices, the Lumen, which is a UVC device. And in 5 minutes, you can very quickly, effectively re-sterilize a mask that hasn't been contaminated. And, you know, looking for opportunities to preserve PPE is going to be so important going forward.
Yes, absolutely. I think there are going to be a lot of things that come out of this like that. So, all right. Thank you all for your time tonight. I appreciate your input. Really appreciate you guys. Thank you.
Thank you.
Thank you.